Tonight's topic is modern acetabular strategies and total hip arthroplasty, balancing, stability, fixation, and versatility. We have an amazing panel tonight, especially good from around the country. They know each other well, and you know them well. I'll have them introduce themselves individually. We'll start with Max Courtney. Matt, you want to introduce yourself to everybody?
Thank you, Ira, thanks, Joey, for having us and putting this together. Max Courtney, I'm a hip and knee replacement surgeon in Philadelphia. I think it's great that you guys are actually educating. If I put my AUKUS advocacy hat on for 30 seconds to give some commentary, everybody has heard about the 20% cuts, 15 work RVUs if you're RVU employed, or $925 for 90 days of care if you're in private practice, on top of what we've been facing over the last 5 years. So I will tell you again, AUKUS is doing everything that we can. I already have 2 trips to DC booked in the next month. We are on the phone with our lobbyists, congressional leaders, and trying to push back. I would urge you, if you have any connections, you can reach out to me or anybody else in the AUKUS presidential line. I have been on emails and phone calls for the last 2 weeks. I have surgeons from Florida. They're going to be writing editorials in the local Palm Beach paper. We have other surgeons that are setting up meetings with congressional leaders in California because Congress is on recess right now. So, if any connections you have within CMS, your local legislators, please reach out to us. It is a full court press. We do need to talk about things like opting out of Medicare. We need to talk about ways, if there's ways we can be collectively bargaining against our employers or against CMS, and we're certainly getting legal opinions on how to do that. So just kind of thinking outside the box here, because there will be substantial access issues with patients coming down the pike. So I'll get off my soapbox a little bit. Looking forward to talking with my
Oh,
friends
great
George and
comments.
Stefano about acetabular revisions.
Yeah. Stefano Bini, you want to introduce yourself to everybody?
Right on, Steve. Thank you so much. Awesome to be on with Max and George. I look forward to learning as much as I look forward to having the opportunity to share some of my experience. I am a professor of orthopedic surgery at the University of California, San Francisco. I'm probably more known for my knee work with KA, but actually about a good half of my practice is hips and about 30% revisions. I do a fair amount of work in that space, and I look forward to, again, having this great discussion about this taboo.
All right, George, you want to introduce yourself there?
Yeah, Ira, thanks for having me. I'm super excited. This platform has been great. It's great to be back, particularly with this all-star cast tonight. I'm just proud to be here. Um, man, I'm a total hip and knee guy. I do about 20% revision down here in Atlanta, Georgia. And to piggyback on to Max's comment before we dive into acetabular reconstruction, I just got my letter response back from my senator. And I was like, not that worried before. And I got the response, and now I'm worried because it was on, I published it on LinkedIn yesterday. You can
Yeah,
read the
I
letter.
saw it.
It's
Yeah.
unbelievable.
This is the one from Ossoff, right?
No, that's the Cooks. This
Oh,
one's from Warnock. And
oh,
between the
Warnock.
two of
Yeah.
them, yeah, between those two guys, we're not in good shape.
Yeah.
Not to get political already, but
That'd be
Though it's
nice.
not it's not a right left Republican Democrat thing, George. It's everybody.
copy that.
All right. So let's start talking about the acetabulum before the STEM people get involved. Um,
So that's
so
worth
anyway,
about 400, right? That's half the hip, so it's a
right.
$400 problem.
Yeah, yeah. Absolutely. So let's start with George. George, tell me a little bit. Let's start off just some general things about how you're seeing acetabula technology changing, developing, helping you more. What's going on with the way you look at acetabula issues now? Just a little acetabula overview.
Yeah, I'm grateful to people that came before, like Dr. Poprosky, who gave us a framework on how to look at acetabular bone loss. And I can remember vividly in training being scared to death of acetabular bone loss and not getting enough of those types of cases coming through. But just a simple understanding of Prosky 1, 2, and 3 type defects where you know what bone is compromised, and then you can get an idea on what you're going to need in your toolkit to fix that problem is kind of chapter 1, page 1. Um, so I think just knowing where the bone loss is, and then the three classic criteria, you have to have immediate biomechanical stability that translates into osseointegration, and let's not forget a stable hip articulation at the end. So those are the three tenets I'm typically worried about.
Excellent. Max, you want to give some comments about where we stand with acetabular technology and maybe what has been some new things on the horizon that have changed from when you first started?
Sure. So, as George kind of brought up, I had the privilege of training with Wayne back at Rush over a decade ago, and just the amount of history that I got to learn working with him, seeing X-rays in the office, and watching how acetabular reconstruction has changed over the last 20 years or so. So initially, we were putting cages in, no biologic fixation. They had catastrophic failure rates. And remember, we were worried about wear. We're not as worried about wear as we are now that we were 20 years ago. But some of these X-rays of patients that I would see in Wayne's clinic as a fellow, you'd see these disaster, the entire hemipelvis and ilium's missing. Somebody would try to do bulk allograft. They'd put a cage in, and they'd have catastrophic failure rates. So then he tried to come up with he would use structural allograft, and it would be distal femur allograft, and he would call things like he would just make up names for stuff. So he called it a figure of 7 allograft because he took distal femur and took a saw and cut it in the shape of the number 7, and that was basically his buttress augment. And he fix it with acetabular screws, and they would do okay for midterm follow-up, 5, 7, 10 years. And then again, I would get to see some of those X-rays and watch the allograft would end up resorbing over time, and then that would fail too. So then he helped develop these porous, both augments and on the acetabular side, and tantalum or trabecular metal, which was made by a company called Implex that was bought by Zimmer down the road. That was the first porous metal that was used in these big acetabular reconstructions. And then, as George said, so we now have biologic fixation where we don't have to rely on cementing a cup into. You now have a metal that has a fantastic track record, and it's been around for over 2 decades now, where bone can ingrow and you get osseointegration of the cup as long as you can get stable fixation along the columns. So now fast forward, I'm young, George and I a decade into practice now. Stefano has a couple years on us, but we're not seeing wear as much. Okay, once in a while I'll see the old cemented cups or some poly that's 25, 30 years old. I think our problems now that we are doing acetabular revisions for, one's instability. So we're changing cup positions, dislocation still a problem. 2 is infection. We're still seeing bone loss and issues with infection. And 3, which I still see a lot of, and George and Stefano, you guys can chime in. We're all at different parts of the country. In Philadelphia, we've been taking care of a lot of taper corrosion, old like Accolade TMZF stems, old ABG modular necks. We didn't do a lot of metal on metal in the Philly area, but we still have lots of corrosion floating around, and those are modular dual mobility junctions. So we're still needing to develop treatments, which I'm sure we'll get into with some of our cases for acetabular fixation from corrosion as well.
Excellent. Stefano?
Are we focusing primarily on revision? Do you want to talk a little bit about just
primaries, yeah, the whole thing, yeah.
Yeah, so I think we've just had a really good discussion between George and Max about how to deal with complex arthroplasty in the cup, particularly in the revision space. We've got bone loss, or in some cases, we're just starting to touch on the soft tissue aspect, largely forgotten as a driver of stability is actually not necessarily cup positioning, but soft tissue issues. So let me just pivot a little bit to big changes that I think have happened in my practice since I trained, which was I'm still trying to get my residents to not do this, but we had to medialize every cup to the medial wall. Everybody had 20/40. And we've learned an awful lot about rethinking the concept of a singular position for the cup. The spinopelvic relationship has become more prominent. the cup ingrowth surface area does not need to be entirely 100% covered by bone. We can now put the position the cup would belong, leaving it a little bit more lateral to not lose your offset on the stem side. So rethinking the position of the cup, and then of course moving into the application of technology for the placement of the components. And I'm talking about orthogrid for anterior hip, robotic assisted surgery, and of course now we've even got some components can be put in with virtual reality. So I think the concept that the cup is not a uniplanar, unipositional component that can be put 40/20 in every single patient. The position of the cup itself, we do not need to medialize the medial wall. We just have to do that for decreasing the joint reaction force. And of course, the poly can handle current reaction forces, allows you to keep that anteversion and adduction angle where you need to be for that particular patient, which varies based on the spinal pelvic, and leveraging technology to get that right the first time. So I think those are big changes since the last maybe 15, 20 years that we can point to as improvements in the way we think about cup positioning. I think that's enough from the primary. Then we can talk about the surfaces, the size of the balls, and those issues, which have both been positive and negative, as Max is pointing out. Some of these innovations over time didn't quite plan out and gave us some issues with metal ion issues, and of course, malseating components, etc. So I think I'll stop there, but I thought it'd be worth discussing the socket itself. This time, the primary is not the primary of 2010.
All right, absolutely. Took a long time to shake off some of Charnley's joint reaction force tenets, and realize that cross-link poly has solved a lot of that,
Exactly.
No question. What about the fixation and screws? George, do you want to give some comments on that?
Yeah, sure. I mean, I briefly on primary. Maybe I'll be a little bit of a contrarian on primary cup fixation. We actually use a standard porous plasma sprayed cup from Zimmer Biomet, their G7. We're going to release our series in survivorship there, which has been a fantastic cup for our surgery center. I don't think we use any other cup for a primary. So I think the debate for osseointegration in a primary is there. We could talk, do you need an advanced porous metal for primary hip fixation? Some people might want that. Does the data support it? Do you need that? I'm kind of giving you an example that we don't routinely do that. I do need a cup that allows for a large femoral head in the poly, specifically a 36 into a 50. And I think what will be coming down the pipe later is getting a 36 into a 48 for ZB in particular. The real debate is, what's your best fixation strategy in revision where host bone is compromised, sclerotic, missing, could be even irradiated bone. And we do have data supporting tantalum specifically in the revision setting over porous titanium. So that's, tantalum is a really appetizing element for your revision to get into this compromised host bone.
Yep. Max, some thoughts on that?
Yeah, I agree. Remember, on a primary, and almost every company's primary cup is going to be fine. You're only getting a third of your cup that's actually going to ingrow, and it's going to ingrow along the columns, anterior superior and posterior inferior. So as long as you're getting a pinch fit with whatever porous primary titanium-based tantalum, porous plasma spray, they're going to have all good outcomes. I think as we talked about, adjunctive screw fixation is a good discussion. We do know that I put 2 screws in all my cups. Not that you need to, and there's plenty of data on that. I work with trainees. I think they need some practice, especially if I'm having them ream and I'm not 100% sure if they're reaming eccentrically or not. It just helps everybody sleep at night. I put 2 screws in my primary cups, but you certainly don't need to. I think on revisions, those screws are generally going straight up the ilium superiorly because that's the best bone. On revisions, we do worry about that stability and that compromised bone. So a lot of surgeons have moved toward finding acetabular components that provide off-axis screw fixation, specifically along the rim, so toward that superior ramus, or along the posterior column along the ischium. Again, standard complex primary, you can put 2 or 3 screws, that doesn't matter. But I do think in the last decade, and other companies have kind of caught on to this. And again, we don't want this to be a commercial for one company, but there are other companies. Smith and Nephew in particular has a porous cup with some peripheral screws, and you got to cement a liner into it. They have a modular one with fewer screw options, but still the ability to do that. But I do think it's really impactful, and you're going to see some cases of ours later to be able to get off-axis fixation, and there's data on that. And we did publish a paper with Roche MGH and Penn looking at that got presented at AUKUS a few years ago. Markedly decreased acetabular failure rate at a mean of nearly 5 years follow-up. The overall re-revision rate for Petrosky 2 and 3 acetabular defects, 11% if you had no inferior screw fixation versus 2.5% if you did.
Define off-axis for us.
So superior ramus or ischium. So everybody wants to fire, and we do have some pictures as we go into our cases.
Okay, good.
We want to get screws up into the ilium. That's the safest. That's the safe zone of acetabular fixation. Usually you can get 35, 40, 45 millimeter screws right up the intertable of the pelvis. And yes, that is the best bone. Unfortunately, some of that bone is often compromised, as you'll see in George and my cases. So you're going to have to find other ways to get good bone fixation. And then we know biomechanically that if you have screws that are divergent, they're going to provide a more stable construct for ingrowth than screws that are either convergent or that are clustered together.
Excellent. Some comments, Stefano?
I will just answer a question. I know a comment on the chat. Look, I think there was some biomechanical studies done a good 10 years ago that showed a single screw that has good fixation is adequate for stabilizing a hemispherical cup. So I've gone to one, not that two is bad, just I've gone to one, as long as it has good fixation. I agree with Max that it does help you, especially in a resident environment, to sleep well at night. Also remember, of course, that there's a viscoelastic. Bone's viscoelastic. The cup essentially is a spring acting against a spring. The bone does relax. If you come back 2 weeks later, that the cup is not nearly as stable as it was when you put it in, and that is simply by mechanics. So having a screw in there to keep that fixation stable while ingrowth happens is really a useful thing. It takes an extra minute. It certainly doesn't hurt, and I agree that I also add one. If I did as many hips as George did, and I was consistent, I probably would feel comfortable without them, especially the newer surface RAs are so good that I don't think there's any problem with aseptic loosening. The reason I started using screws in the first place, I don't know if you remember the data out of Sweden, I think it was, that looked at cemented versus ingrowth cups, and cemented cups versus ingrowth cups. Ingrowth have had a very, very late failure rate. They're at a 10 to 12 year time frame on that registry. I think the cups have gotten better, and that's no longer the case. But that was where it comes from, and I think there's an element of historical use case that may not be indicated anymore. George, you don't use any screws, it sounds like.
That's really evolved over time. I would say almost everyone would get 2 screws for a while when I was in practice, early in practice. And as time has gone on, my screw utilization has gone down. But the way I prep an acetabulum is drastically different now. I do rely on fluoroscopy. I'm not super tech heavy, but I do use imaging. And it's super helpful to know that I have enough coverage, that I have the right size. These concerns that you guys mentioned about eccentric reaming, whether I'm reaming something out or my fellow is, I'm less worried about it because I can see it in real time. So the amount of minutes that I'm like butt puckering, watch a resident or a fellow ream is way down. And it's a very much a percutaneous technique. And so I felt a lot better about the press fit I'm getting on a primary doing it that way. And so my screw utilization has come down a lot. Yeah.
Let's look at some cases. Who wants to start off?
Hey, Ira.
Oh, yeah. Kevin, again. Kevin Blanchard.
First of all, it's great to see George, Stefano, and Max. I'd like to be the contrarian for a second because Stefano said it. So if it's not 2010 any longer for the three of you, why are there so many recalls of prostheses in the last 15 years? Why are there so many revisions still going on? Failures is high. What's missing in the innovation of a total hip? And when I hear, sorry, I'm older, that late failures at 10 years, if I was a patient and told I'm only going to get 10 years, now that we're doing 50-year-olds, I'd tell you to take a hike with that operation. I'm not interested in you. So help me for the young people to say, maybe we're not there or we are. And all these companies inventing this newfangled triple taper, and I got it. Help me because I'm
Kevin,
53.
Kevin, show me the data. What are you talking about? Cups. We're talking about cups, not stems, and not
Okay,
cups loosening or aseptic loosening or infection, which is
fair enough.
separate. But cups that have loosened that have been released since 2015,
Right.
name one.
1 second. I apologize that I was approaching for the younger people because there's a lot of young people here about total hip replacement and understanding, is this an operation someone should undertake at 50 years of age if they're only going to get 10 years and
I tell
fail?
my patients that hip replacement is a lifetime operation, lifetime at any age.
Yeah, Kevin, I hear your concern, and I'm young enough to have lived through metal on metal and modular necks and stuff too. But I think it is on the stem side. I mean, we have highly cross-linked poly. I tell people the same thing, Stefano. I tell them if you make it past 3 months, it's going to last you the rest of your life. Fracture, infection, dislocation. Okay, infection can cause later. I think what are some of the problems we still need to solve? Instability. Yeah, we have larger heads, and we haven't figured that out yet. And maybe it's cup positioning that's going to be different for people, and hip spine.
Right.
Um, I think a lot of the failures on the I think Biloc's fourth generation ceramic has solved a lot. Seen three ceramic head fractures from the newer ceramic, and I take care of a lot of revisions in the area. So I think we've solved some of the bearing surface problems. And again, I don't think we're seeing cups get loose. So
Great. Then
revisions.
I'm happy to guide it along, but I think we had to say that to the people sitting in the audience because you guys are brilliant, and I want them to make sure they're taking the lead. So thank you, Ira,
Yeah,
for
but
that.
Kevin, if you get on Google Gemini and you ask it how long does a hip last, it is going to spit out 10 to 15 years, which is shocking to me.
I agree. I agree.
That is the public data that is available. So young patients do come in and ask this question. The reality is around 2003 or so, when highly cross-linked poly kind of came into play, we have this biomechanical wear data out 46 years, but the poly hadn't been out 46 years. We do have CT scan data looking at 20 plus years with minimal wear to minimal to no osteolysis that looks like that 40-year wear prediction is mostly accurate.
Uh-huh.
So to your point, for as wear as an endpoint, I'm not as concerned about it. I myself would have a ceramic on poly hip today and move on.
Thank you.
All right, let's start with a case, as
Great.
it says here. I'm just reading from the screen there, George.
Sure. So
So
I'll
Max,
start.
this
I
is
know
Max.
we have a couple too. So this guy's he's 69. He had a lot of treatment in Puerto Rico, and then emigrated to the mainland in the mid 2000s or so. He had a acetabular fracture from a car accident in Puerto Rico over 20 years ago. Had it converted to a total hip about 6 years prior to when I saw him, and he's now had three posterior hip dislocations. So, and they've been minimal trauma, bending over, crossing his legs, standard medical comorbidities. He's otherwise in pretty good shape. And I don't think any of us want to talk about infection, so none of these cases are going to be infected. We can do a whole nother webinar for that one. So other than that screw from I think what was prior acetabular hardware that's protruding in his bladder, what do you think's going on here, Stefano? Why do you think he's dislocated? What do you think about the cup positioning?
Right. So lots going on here, right? So you got a cup that looks a little superior, it's a little flat. But I think the biggest issue is that it's leg length, it looks like quite short on the right side compared to the left image. This is a gentleman with a very long femoral, valgus femoral neck, and the implant that was selected has a short varus neck and a short head on it. So my guess is this patient was very tight at the time of surgery. The surgeon had a difficult time probably reducing this. When I put a calf proximal, thought he had it right, but it turns out that over time, he's soft tissue envelope relaxed, and I suspect he has a decent shuck. And my suspicion is his number one issue is that he's short, more than the calf position itself.
Yeah, I agree. And again, I never want to throw stones from my glass house. I have plenty of dislocations. I have plenty of fractures. I have plenty of horrible x-rays out there. And none of us were in the OR. This was obviously a tough case. I mean, apparently this guy had a bunch of other screws. I didn't see his x-rays from Puerto Rico or from his index surgeon, but I would anticipate the same thing. I bet he probably had close to like an auto-fused hip with this high hip center from this bone erosion that his head had collapsed. He'd probably been short for a decade plus because he's had neglected care, and it was really tough for this surgeon to get the hip center and try to bring it back down. So I don't think anything's necessarily loose, but George, how are you going to tackle this? I mean, you want to go start pulling that stem out right away because he's short and we want to get more length?
Yeah, I don't think so. I think you're asking for trouble there. I'm going to classify it as like an AML-like stem. I think it's probably coated most of the way, and I don't want to get that out, which means you're going to have a good exposure, right? You're going to have to really mobilize the femur out of your way so you can work on the socket. This seems to be a socket malpositioning issue. So you want to cut that cup out. And you have to kind of, if you're going in for a better cup position, you need some mechanism of making sure your new cup is in a better position. So you're either really good at surgery and you can do it just eyeballing it. You can use fluoroscopy, X-ray. You can use technology to help you get a new cup position. But you need a cup that's abducted and anteverted appropriately. You can get it probably a little bit lower in the acetabulum, but maybe not a ton lower. Um, and once you get it appropriately put in place with screws, then getting them back out to length might be a challenge. You can do serial lengthenings, interop with a small ball and like keep going longer and longer. But if you just restore this patient's leg length and offset with a reasonable cup position, you'll be in business.
Yeah, I think that's a good point, George. So again, I think a lot of people want to go to like revising the stem. That's how you're going to get length. You're going to max out the ball head size, but you can bring the cup down too. And if you try to put in, he's a bigger guy. I'm sure we could have done a jumbo cup and maybe gotten like a 68 or a 70 millimeter cup on this guy. But there's a couple issues with that. I think by having such a large cup, you're going to have the tendency because of the bone loss pattern, because it's more acting like a 3A once you get that cup out. You're going to have the tendency to put your cup too vertical and too retroverted because you're going to try to accommodate the bone loss pattern. And then when you go up such a massive cup size, you're going to be raising your hip center and you're going to be maxing out the head size too. So instead, if you put a smaller cup and you bring your hip center down, so I took a flat plate when I had a reamer and an augment in. If you were doing this DA, you're using it under fluoro, but I agree. You want some type of radiographic confirmation. And this is what we did. So we put an augment in for primary support. So basically reestablishing the anterior column to bring that hip center down. And then we're able to put in the cup. So remember, augments can act as two different things. They can be for primary support or they can be for supplemental fixation. So if you get a good cup and get a good column fit and maybe half your cup is overhanging, then you're going to put the cup in first and then flip the augment around and act it as a buttress. And every company has different types of augments. Again, try not to be too commercialized here. But I do think one of the benefits, what I used to do, and you can kind of chime in too, because I know you did a lot of Smith and Nephew stuff in the past. So I would use in a case like this, the fully porous cups because they're thin and they're flexible. And if I was a little vertical or a little retroverted, you're cementing a liner in anyway. And you were able to get rim screws. You could take a metal cutting burr and get peripheral screws. Again, you're going to use fluoro or X-ray or your anatomic landmarks. But I think with some of these newer cups, and this cup in particular, one, not just having the trabecular metal fixation, but having the ability to use a modular liner. I mean, it's saving me 15 minutes a case not having to cement something into this. So I think that's the benefit of this new cup. And we did it kind of exactly what you said. So we have that 20 millimeter augment to bring the hip center down. And again, look at the off axis screws. So I think I was able to get one up in the ilium, and we were able to get two or three of those, the rim screws that you see. And those are more peripheral to the locking mechanism. So that's why they're able to get good bites. And then just like any other company's cup, you can do, I don't like putting constraint in a fresh cup, but you could have done dual mobility. You can do a lateralized liner, which I don't think I did on this guy. And you have different liner options you don't have to worry about cementing stuff into.
Go back to that picture one before. I've got one like it, but if you notice how many screws you could potentially get into the ischium there, you've got like three peripheral screws you could get, and if you wanted to, you could get a few more in the cup itself. And so,
And then
hitting
there's
the
three
ischium,
three in the
yeah.
poster column too. That's behind some tissue.
And historically, like getting a pubis screw is kind of nerve-wracking. And Neil Chef has a technique on how to hit that pubis screw with a Steinman pin and kind of putting the cup over the pin. And I think that's a great technique. But if you have three peripheral screw options, you can find the right one for that pubis screw. Uh, so this picture just shows that very well. Nice job.
And to your other point, you have more screw options that are in the cup too. So you're not limited by like the locking mechanism, and some of the cups can take up some room inside of the cup, and you might only have three or four different good screw options up in the ischium. But even on the X-ray, you can see we were able to get a couple screws up the ilium, which is those superior screws, which are good bone there.
So I have a question for you. If you go back to that, if you
Sure.
don't mind, I'll take Kevin's job for a second and be a little bit push back a little bit. Let's just say that you're not a skilled acetabular revisionist and not that comfortable with augments. Go back to the first the presenting slide. No, sorry, the presenting slide. Do you think there's a world where you at least try, assuming that cup, you know what the cup was, you know what the stem was, you know what the head was, where you could try lengthening the head and putting a constraint liner. Let's just say the guy is 65, not particularly demanding. Would that be such a bad idea not to try to? Because when you take that cup out, there's not going to be much posterior wall. You did exactly the right thing by putting a small cup in, but that still looked like that's a high level decision making that we were here to talk about. But do you think it'd be such a bad idea to try to extend the leg and maybe put a locking system in it?
Oh God, I've tried that, and I love less is more, right? Big surgery is bad for people, okay, in general, like to your point. That being said, when I have tried to get cute with these, so to speak, and do modular part exchanges with this amount of acetabular malposition, it has not worked out for me. I can't say 100% of the time, but more common than not, they still end up with some sort of instability afterwards. And also that constrained liner, of course, we're trying not to do because they're impingement machines. And this guy's mechanism for dislocation is already impingement. So I think to lock this guy down, he'd probably do okay with a constrained liner for 3 years, and then you're going to be back. But to your point, if you're going to do a big surgery, you better be good at it. Like you're wagering things like you're not going to break the troch off. You're wagering things that your new cup position is going to be good. And so you got to know your limitations as a surgeon. If you're used to doing this, you're feeling good, great. If not, it is okay to either use technology or have another surgeon help you do this.
Last question, same case. Max, you had this guy come in from, you said Puerto Rico, I think. We have people come up from Mexico, from Chile, from Peru, and sometimes these stems look familiar, but when you get in there, it's not the companies. How do you get ready for the situation where you think this is an AML or you think this is some stem, but now you're stuck with the one ball it came with because you can't figure out the taper?
Yeah, so that's a great question, and we struggled with this one too. I'm pretty good. I'm not great at it. I give myself, I'm a B plus at identifying stems, and that's just from doing enough revisions. But I will shop it around to friends, and we'll be texting people like you guys to help find it. And I got like 3 or 4 different answers for this stem. So I had a couple of head options. It's actually a Biomet integral stem, and that
Mm,
was not my guess.
okay.
So luckily we have type 1 heads. And again, doing this at a hospital that you have, so we at least have at our hospital, we have Depew Smith and Nephew Zimmer Striker and Biomed heads and Legacy Zimmer heads all sitting on the shelf. Now, if it's a surprise from a smaller company, then, and yes, I've certainly been surprised before, you might be pulling a stem. I'm not a huge fan of taper mismatches, but yeah, you just got you got to be prepared. Okay.
Excellent.
And then I'll do my last one. It's very similar. And then I think George will have a couple too. We kind of talked about indications for revision. So this lady's 78 and she had a hip about 14 years ago, had a Vancouver C periprosthetic fracture, fixed slightly more recently. She has, again, we're not talking about infection, but she had a cobalt level of 4, and her chromium level was barely above normal. And she came in with these x-rays. So, George, what are you kind of thinking about this particular case? This is probably a 3B, maybe it's a 2C.
Yeah.
Walk me through what your plan is on this one.
Yeah. After
You
you've
see what
ruled
I
it.
did, which is the
Yeah.
same X-ray as before.
Um, and you've ruled out infection, and there's already like the trochanter is already not in a good spot.
Yeah,
Um,
and you see that I broke it taking the stem out too. So,
And like the stem, I think is probably well fixed. But once again, like sometimes you just can't get great exposure, and sometimes you have to take the stem out. And that's just something you got to tell the patient. I mean, this is a super high risk trochanter. But on to acetabular fixation, on a 2C, a Poprowski 2C, hopefully you can ream away your problem, so to speak, meaning you can go up in your acetabular size to fill the defect from top to bottom and get a big enough cup where it doesn't go back into the pelvis. The problem can be is the dimension of your anterior to posterior walls. So if you can just ream up and put a cup in and get fixation into zone 3 and zone 1, you're in business. I think as a plan, I see what you did here, which is thanks. You're helping me out a lot there. But there's a little bit of uncertainty in what is going to happen during this case, and you need a plan to get out of there. And so you want to have augments and potentially a cage backup. And Lord knows I hate telling the reps to bring this cage back up, but this is that sort of case. If you found like an occult pelvic discontinuity here, that's on the list. You got to mentally be prepared to deal with that in surgery.
when are you bailing to the fully porous cups? Again,
Yeah,
that's going to be the ones where you can take metal cutting burrs and drill your own holes. They're thin, they're flexible, but they don't have a locking ring, and you have to cement a liner in.
which makes them tougher to use, but they still have a role. So the biggest issue is if you have a feeling you're going to go to a cage, the G7 TM revision modular shell, which we're showing some cases of tonight. You could do a cage, but the cup is a little thicker. The cage is not exactly designed for that cup. So you would use a traditional T-Mars cup to put the cage in. That's probably the main reason that I would go to a monoblock TM shell is if I knew, I needed a cage um, to answer your question.
Okay. Stefano, are you doing any of the fully porous cups, or have you think these newer modular cups have kind of solved at least 95% of your revision cup problems?
Yeah, the answer is yes. They have resolved 97. Where the larger cups come in is in larger patients. This is a small patient. I wouldn't expect to have to put a huge cup, but there are some patients that are very large, and you only have 72, 74, 76 cup. These cups just don't come in those sizes. So for those very large defects, I agree with you guys, and we'll use them. And I just did one recently, and it will work. It continues to work great. The occult fracture question is a really good one. Most of your wear here, a lot below is anterior, right? It wasn't so much posterior. Your posterior column was still intact. Is that what you found when you got in there?
Yes. Yeah.
Yeah.
No, luckily, it wasn't a discontinuity, but certainly, as George said, we're ready for it.
Yeah. And you make a good point that not all the cages fit in all the cups. So you have to be aware of how to select your cup choice so that your cage will actually allow you to bridge the gap. And you guys do mostly cup or cup cage only. There's a big interest now. A lot of people doing cup cage with a cup inside the cage to get that modular liner. You've seen that probably.
I've seen
Yeah, I
people
don't know that I have room.
cement
Once
in
I
like
do
one
a
of the
cup
dual
of
mobility
cage,
cups.
the inner diameter is getting small on me. So
Yeah.
you could cement in a cup that like a monoblock, like to use a trade name like a Smith and Nephew Polar Cup, right? You could cement one of those in and get a nice size dual mobility. So I do that for sure from time to time.
And I'll do that in like the fully porous cups too. So that's kind of what we did. And we're not talking about the femur, but I'll be honest, I was more scared on the femur on this side because that's like a 27 millimeter diameter stem and she has eggshell bone. I just took the screws out and luckily she's probably about 2 months out. And then obviously I'm going to plug my own research, but this was a multi-center ACA study. So if you guys want to look it up, but having that inferior screw fixation, again, whatever company you want to use, but having those off-axis screws really did help minimize revisions.
So let's talk about that for a second. Very frequently, you put that screw down there in ischium, either one, and it has zero purchase. So my backup on there is to inject some cement. Have you guys done any of that, or do you find that you can usually get decent fixation?
I
I'm
find
thinking,
I can, if I can't get fixation on the superior ramus, because sometimes you maybe didn't get your hip center down all the way. If you didn't get your hip center down all the way, it's okay, but you might not be able to get those superior ramus screws. But I usually the ischium you can get good screws into, and you can get 35s. You can get screws into the posterior column into the ischium, unless it's some massive osteolytic case.
I've got some great pictures of that very thing coming up. I think because I'm cheating with intraoperative imaging, sometimes I can get bicortical ischial fixation, um, and maybe get down the ischium a little bit better. But you're right. In an osteolysis case, traditionally you get ischial osteolysis, and then you are correct. You're going to have either poor ischial fixation, and you're looking at the pubis. You're worried about the inferior fixation for sure.
We have a question, Peter
The good old
Paulson.
trick.
You want to ask your question on impaction grafting, or Max? You want to answer that, or?
Sure. Yeah, it's just a question on paction grafting. I'm not doing it. Maybe again, Stefano, you maybe have a little bit more experience. I'm doing it on the revision knee side, maybe once a year. So if I couldn't get that 27, 28 millimeter Arco stem to sit, I would have done like a long CRC stem with impaction grafting. That was my bail out there. But I still think there's a role, not frequently, but we don't teach it enough. And there's absolutely a role. The data is still very good.
Awesome. Awesome. George, you want to pop up a case or two here?
Yeah. Let's see. I've got one decent case I hear. Let's see here. Are you seeing my screen?
Yep.
Excellent. Okay. Let's get right down to it here. This is a 67-year-old lady. As discussed earlier, she came to me from Birmingham, Alabama to Atlanta. It's amazing how people will find you. She had had multiple left hip surgeries at this outside institution. She is a very healthy lady, which is usually not the case. She's a ton of pain with weight bearing. Her hip problem list is that she has a chronic PJI, she has a chronic discontinuity, and that she's a chronic dislocator, the triple play, so to speak. So she comes in with this X-ray failed constrained liner. Stefano, you'd asked about that earlier. This is like a good example of why we typically don't like to do these constrained liners because of this exact problem. So first things first, I had to get all that out and start over with this spacer to get rid of her infection. And when I did that, I discovered the discontinuity. I didn't know that she had that at first. Um, so she's got this. I know she's got a discontinuity, and we got to figure out, what we want to do. So, here are the goals here, but maybe we just get a quick answer from Stefano and Max. How are you going to approach this case with a big acetabular vault discontinuity? The femur side is relatively straightforward, but this is really a socket question.
Yeah, I guess we're going to have to bridge that. The question I have in my head right now, is this going to be a straight up cage, or do we need to do a 3D printed tandem spacer? How much wing did you have left? It looks like it's a very thin iliac wing. You passed the acetabular component. It's probably just a bridge, a very thin bridge up there.
Pretty thin, pretty thin.
Yeah.
She's a little lady,
Yeah. That's and you're right up there against the superior notch. I think you said she's healthy, otherwise spine's fused. Yeah, I think you should be able to get away with the cage, and I don't think maybe a cup cage. Yeah. It looks like you have enough room for a decent sized cup. I think this might be one where we might use a straight up TM component, and cement a cage into it, and then a liner into that. That's how I would probably approach it.
I think that's a reasonable approach, is considering a cup cage. Max, thoughts on adding to that?
Yeah, so discontinuity is obviously really, really challenging problem, especially in the setting of her infection history. Your options are one is my preference, which is acetabular distraction. Again, I'm a Wayne Paprosky disciple, and I'm going to be the minority of people on this call that'll actually be promoting distraction. But it works, right? It's really a chronic non-union of an acetabular fracture, and you are basically trying to use the cup as an internal plate to bridge the defect. So we'll open it up. I got a lamina spreader. You can ream maybe 6-8 millimeters larger. This one's probably going to need an augment to bring the hip center down. So I'm probably going to use a 15-20 millimeter augment, bring the hip center down. I'm going to distract through the augment and the ischium and the posterior column. And these cases, I'm still going to use those fully porous trabecular metal cups that are thin or flexible. They'll accommodate the defect. And then you can use the metal cutting burr with screws, and you can cement in whatever your liner of choice is. I think a custom triflange is not wrong. If you look at the data, custom triflange actually does reasonably well. My knock on the custom triflanges are up to 20% incidence of instability, because you don't have the ability to change the cup. Then even if you're going to put in the porous cup and you put it in a little vertical or retroverted, you're cementing a liner in. So you have the ability to antivert that or make it a little less vertical. But I don't think triflange is the wrong answer. And then what Stefano talked about, which is I wouldn't use a cage alone. There's no biology there. But some people have described and talk about doing cup cages with reasonable outcomes as well. They're the three.
Yeah, I knew I liked you guys. I mean, we are so like-minded. This was an anterior approach for me. This is kind of a quick peek at her acetabular vault. That is exactly what I did. Here is her trabecular metal augment, probably about a 20 millimeter, that I am planning to distract against. It wasn't a particularly unstable discontinuity. Like if it's an acute discontinuity and you got two piano keys, you got to plate those. This, had some stability. So here's kind of a look at that, right? So we've got the augment. Here's the G7 TM cup, and it is at least 6 millimeter bigger cup than what I had reamed for. And some people do put pins and distract with a lamina spreader. I think that's great. Sometimes you can distract by just jamming it in there. And this was a jam it in there sort of distraction. And I could see the pelvis distracting on fluoro as I'm doing it. And this was rock solid right here. We didn't even have screws in this cup. And then as we go, the question comes up for us DA revision folk, is this cup radiolucent? Tantalum, if you think back to physics and the periodic table, has an atomic number of 73, and titanium has much fewer protons. So these can be radiopaque, but if you look at the fluoro, you can see the ellipse on this cup, particularly a bigger cup like this. Here's a picture of some of the screw
So
holes.
George,
Yeah.
comment a second. So if I had, say, the Acetabular G7 or a multi-hole company cup from another company, would you have gotten that much of a bite? I tried. I would not have been comfortable just putting in a thick titanium plasma spray cup on a case like that.
Yeah, I think you're bringing up some points. One is the tantalum surface for biologic fixation. The other, particularly for a case like this, is the ability to get multiple screws into the ischium and the pubis safely. And then in this case, it's modular, so I can just put a dual mobility in at the end with this distraction. So this case actually didn't take that long. There wasn't a lot of blood loss. I mean, it really streamlined the surgery. And maybe this isn't the best pubic screw ever done. You can see my drill bit kind of going through the pubis. I could have been a little more, I guess, down the pipe of the pubis, but I was pretty happy to get a 30 millimeter, peripheral rim screw into the pubis and a few into the ischium here. Um, this cup is designed with Zebra technology, which is based on Zimmer Biomet's proprietary system of 3D CAT scans that looked where the best bone is. And so these screw holes are designed in two arcs for right and left hips so that you can get the screws in the best place. And if you here's just another schematic of that. And Max, this is what I'm saying. Like this picture on the right looks just like your picture, right? Uh,
100%.
it's an augment with a TM cup, and you can see all those peripheral screws I can get. So, like compared to maybe somebody else's cup, which you mentioned earlier, like yes, there are screws with locking screws, but you can get like one screw into the ischium, where here you could get like up to 4 or 5 screws depending on how big the cup is. And so here's just a picture of some of the final construct. We did just a Z1 stem on the femur, as a primary. Just kind of this is a couple of weeks out. This is her 7 months out, and still doing fine. I'm kind of thinking her discontinuity might be healing some. Um,
That looks awesome, George.
Yeah,
That's a
really
cool
good.
case.
That's really good.
you could throw a little egg at me for the skirted neck and the dual mobility, but she's going to do great. I'm not going to sweat about that too much. You guys have comments on this, what we did or why we did it, or
Yeah, I mean, just pointing out exactly what you said. I mean, you have at least that I can see on the X-ray, one, two, three of those monster and they're not 15s. They're like you said, they're 30s off-axis screws for your fixation.
That's
yeah.
probably one of the take-home messages of the last several years has been the importance of those inferior screws. And I think we did a good job in the course of this conversation to continuously point out the importance of those. It's worth spending a minute to line them up. I think Steph's technique of putting a pin in and then sliding the cup over is a good one to remember.
So, George, I'll give you a kind of a contrarian thing. I've allowed, and it's only been my last like 3 or 4 patients, weight bearing is tolerated.
Yeah, I thought about it. I know she wanted to. I almost always do. I think I backed her off for a little bit.
Maybe with the discontinuity, I do think that's another study down the road. Because I've been quick to let my femoral revisions weight bear right away, but I've always been worried about the cup. But I do think we might see a role for earlier weight bearing as we get more fixation.
They auto protect a lot anyway, so the obligatory question, like the number one question you probably get about this cup is what about the locking screws? And I'd love to hear what you guys have to say about it. I will just say we did do some biomechanical testing And the peripheral rim screws, along with the tantalum, you can see on the schematic on the right that the micromotion is less with that scenario. So, like I said, you can get multiple screws per bone um, and have great fixation without locking screw fixation. You guys have any thoughts about locking screws versus compressive screws?
Yeah, I could.
Personally, I'm not a huge fan conceptually. I never really understood the concept. I really do want that compression on the screw as opposed to locking it. Suppose if it's particularly osteopenic bone, or if I'm going to do something like adding bone graft or cement to first stabilize a big osteolytic defect, I may want to have basically a blade up there, but I'm not a huge fan conceptually of the lock screw. Now, people they often say they like them, but I'm not really quite entirely. I just don't get the concept. I think the purpose to bring the bone to the cup to the bone, and to have as much compression as possible, you can get it. We know how quickly they lose the bite, and how I talked about earlier the viscoelasticity, elastic properties of bone. Really, you need to have that compression fit. Um, so I think you guys kind of agree with that.
Yeah, I do. I mean, I think you definitely want compression. There might be a role for a locking screw or two, but there's also engineering compromise by putting locking screws. So those screws, they're going to be thicker. You're not going to have the variable angle that you would on the non-locking screws. They're also going to have to be spread further apart, so you're going to have fewer of them. And I don't know if the engineering compromises would make sense either.
And the last second of this, I think we're almost done. But do you guys routinely put dual mobility cups in all your complex reconstructions?
Basically, yes. And the reason I do that is from that study out of Mayo that looked at large femoral heads, which they defined as 40 versus dual mobility. And the dual mobility did have a better survivorship, to my knowledge. Whereas the chances of me putting a dual mobility in a primary is about zero. That's just my own bias. But for revision, it's a different animal. And usually it's a scenario kind of like this. She already failed a constrained liner. She was a multiple dislocator. I was pretty darn happy we could come back with a dual mobility and keep her stable. And this cup, I'll tell you, was a 68 millimeter TM revision shell. You can get a very large dual mobility in a cup of that size. So, like, there's at some point when you get to a certain diameter on your dual mobility, you're really getting a lot of bang for your buck. If you have a 48 millimeter cup and you have a 36 or maybe a 38 millimeter dual mobility, you're getting less bang for your buck on the small size. When you get to these gigantic sizes, you can get a dual mobility like a 50. That has a long way to go to come out. So I do see the value on the revision side.
This is
Max, you say?
amazing. So go ahead, Stefano. Yeah.
No, is it
Yeah,
Max?
I couldn't agree more with George. We'll keep that short.
So this has been, as we always say, the fastest hour in orthopedics. All you guys could have gotten 3 revisions done in this time period. I know that, but we'll keep it at that. I would like to ask each of you to just please just give just a little advice to the audience and on taking on these cases, or just a little bit of a summary. We'll start with George, go to Max, and Stefano, you'll bring us home. George.
Just like anything, a man must know his limitations, Ira. And so, you know, you got to be able to do it, your facility's got to be able to do it, and your team has to be able to handle it. Because they are going to generate a lot of phone calls. Stuff does come up with these cases. I will also say if you're taking on a lot of complexity, don't do it all at one time. Like you don't want to have 20 balls up in the air all at the same time. So if you have a lot of these cases, try and space them out just so you can manage them appropriately because they do need more attention.
Excellent, Max.
Yeah, I agree, George. And I did not heed that advice early in practice with those multiple disaster balls floating around at one time. I think in addition to what George said, you guys still should be comfortable because you're going to have complications associated with hips, and you should be comfortable taking care of simple stuff, not some of these discontinuities and 3B defects we showed. So my advice would be Do not get lazy with head and liner exchanges for revisions. They rarely work. You probably need to change the cup. And then again, same thing in the infection side. I would be more aggressive being able to pull implants. I'm doing more and more single stages. There's certainly roles for dare, but especially if you don't have well fixed implants and you're 6 weeks out and you get an infection, do a single stage, and you guys can use these revision cups in scenarios where you still have a lot of bone left.
Steph, you want to bring us home?
You know what? Let me take a different angle. Again, I look at Kevin. I'm like, I gotta think different because Kevin's here. It's look, get it right the first time. I think that the prevention is the biggest is what an ounce of prevention or a pound of cure. Obese patients, the short counter never gets out of the way enough. You think you got any version, you don't get an X-ray. The making sure that you understand if there's a spinal pelvic issue, to make sure you have enough antiversion. The testing for soft tissue instability. Some patients are just very lax. Those are not the ones you get perfect. You need to lengthen them a little bit, offset them, make sure you understand your patient's general biology. Again, the last piece is if you're going to go into this, I think Max's case is a perfect example of it's really, really important to take the minute to figure out what stem you're dealing with. Make sure you have head sizes that you can modular head size, otherwise you are going to be very limited in your reconstruction of the acetabulum. With that, I think that was a great session. And I did learn more than I thought. Perfect. Exactly the way I like this thing to end.
Awesome. Awesome. I'd like to say thank you to the whole panel and to everybody who participated tonight. This will be available on YouTube, Spotify, ViewMedi, and even Apple Podcasts. So I want to say thank you and good night.